Good afternoon all. Welcome to the Regional Distance Learning Seminar Series. Today's RDLS session will be taken by Dr. Gautambir Singh on the topic ENT manifestations in pediatric HIV/AIDS patients. Dr. Gautambir Singh is currently working as Professor, Department of ENT at Lady Hardinge Medical College and Associated Hospitals. He is an alumni of Pandit BDS PGIMS Rohtak, and after finishing his PG in 1997 has worked as faculty in many prestigious medical institutions: GMCH, Chandigarh IMS, BHU, Varanasi and VMMC and Safdarjung Hospital, New Delhi. He is keenly interested in academics and has more than 65 indexed publications in various national and international journals to his credit. He has presented or co-presented 25 scientific papers and 26 posters at various national and international conferences. Professor Gautambir Singh is an editorial board member of journal Clinics in Surgery, Otolaryngology, Otolaryngology and Hyperps, Otolaryngology and Rhinology. He has organized 2 national level workshops on temporal bone dissection and cadaveric face dissection. He has attended more than 125 conferences and workshops in accordance with continuing medical education and has been invited as faculty in more than 70 of these academic events. Professor Gautambir Singh has keen interest in otology and face. Now I would request Dr. Gautambir Singh to start the session.
Good afternoon, doctors. I would be talking here about the ENT manifestations. I would be talking here about the ENT manifestations of AIDS in the pediatric population. So let us first begin with the epidemiology. Now we all know that the first case of AIDS in India was reported in 1986, and the current HIV prevalence in India is about 0.22%. The good thing about all this is that there has been a general decline in the trend, from 0.26 and a year before that we had it somewhere around 0.32%. Now the new cases diagnosed with HIV/AIDS are about 86,000 every year. Now what is more important here is that the 12.4% of these patients, they belong to the pediatric group. So there you are, 10.4 thousand patients every year are going to be children who are going to manifest themselves with the ENT symptoms of the AIDS. And 80% of cases of HIV and AIDS, they have ENT manifestations. So you can imagine, sometimes that the patient may not land up with a pediatrician, but on the contrary, he might land up with the ENT surgeon, number one. Number two, 55% of HIV children, manifest with ENT symptoms by the age of 3 years. So that is a sizable number. And much more than that, that almost 100%, if you see 98% of the HIV children are less than 9 years of age and they are diagnosed with the ENT manifestations. So this slide you can see here that the importance of ENT manifestation in children. That's why I kept this slide, that 80% of these cases of HIV/AIDS, they have ENT manifestation. So that is the first message I want to give you. Now let us come on to the classification of the AIDS. Now this is a classification. I think all of you can see the references about that which I have put here down, both these references. But here you classify AIDS into 4 groups. You have, one is a non-symptomatic group, then other is a mildly symptomatic group where you have a cervical lymphadenopathy and neck symptoms, basically parotitis, and then you have a moderately symptomatic group in which you have candidiasis, you will have herpes simplex virus or a zoster disease, okay, and then similarly you may have a severely symptomatic condition where you have opportunistic infections like tuberculosis, pneumocystis jirovecii, you can have cryptosporidium, all these rare sort of things, lymphoma, encephalopathy, wasting syndrome, all these rare conditions are manifest in the children. But so this is how, this is the clinical classification of the AIDS, on the basis of which you can, you can grade your patients. Now, what is more important is, what is written here on the left side of this slide. Now, here you remember here that all these symptoms are suggestive of AIDS. They are not diagnostic. So that is very important, number one. Number two, if in an untreated patient, you will always find that these symptoms keep on progressing, deteriorating, in spite of your initiating medication. So this is very important. If you give routine, treatment to your patient, say to a patient of oral thrush, and he doesn't respond to the treatment, then you start suspecting that yes, there is something wrong. There is something wrong in your patient. He or she is having some oral lesions. And then, of course, if your patient is on a treatment, that he's taking the retroviral treatment, and in spite of that, if you start seeing this ENT manifestation, then it is an indication that your this treatment, the retrovirus treatment, is undergoing failure. So always remember these few important clinical points regarding the ENT manifestation of the AIDS. Now, there are some other important things. Now this has been our observation, and this is what has been recorded in the medical literature as well, that there are certain predisposing factor for ENT manifestations. Number one, a CD4 count less than 200 micron liters, the HIV RNA levels of more than 3000 copies per ml, if your patient is having xerostomia, poor oral hygiene, and smoking. Now, I know all of you are going to get alarmed when you will see that you have this smoking coming in, but what is there, since we are dealing with an adolescent age group as well in the pediatrics. Now smoking has really become a big issue. Children have started smoking earlier on, 12-13 year onwards, and these is regarded as a very important predisposing factor for the manifestations of the ENT manifestations in HIV patients. Smoking as such predisposes us to a lot of problems, but now in AIDS also they say that if you are a non-smoker, you are least likely to have the ENT manifestations. Coming on to the what are the various kinds of lesions that we would be seeing in our patients. So they can be broadly categorized into four categories. The one is the oropharyngeal manifestations, the second is the neck manifestations, and the third is the otological manifestation, and lastly you have the rhinological manifestations, and I have put them in the order of their prevalence. That is, you're more likely to have an oropharyngeal manifestation. This is of course followed by the neck manifestation, and then you have the otological manifestation, and then you have the rhinological manifestations. Although the neck manifestations are the one in which you keep your patient in the mild category, but you must remember here that they are not the commonest presentation for the ENT manifestation of the AIDS patient. Now let us see the other important thing here. What are the various oropharyngeal manifestations that can occur in a patient or in a pediatric patient? We all know oral candidiasis. It's a very common involvement. We all see them in AIDS, known as the oral thrush. It is seen in 22 to 84% of cases, and it's recurring, and sometimes it's persistent, and the babies who are not breastfed, they are the ones who are most likely to have this oral thrush. It may be pseudomembranous, associated with erythematous and angular cheilitis. So that is perhaps very important. The treatment for this, well, you have to give an antifungal, clotrimazole, nystatin, and fluconazole. In our experience, we have found that most of these patients, they land up in the resistant category. Now we are in a tertiary care center, and that is why I have put that with the yellow one here. In resistant cases, you have to use what is known as an itraconazole, 2 to 5 milligrams per kg body weight per day for 7 days, and sometimes even you might have to use amphotericin B. Now we have had resistant cases where we had to use lysosomal amphotericin B as well, but most of the cases who are detected earlier on, all that they required is clotrimazole, nystatin, and fluconazole. So that is what is a general message here. You also have other things. You may have periodontal and gingival diseases, and in that you have linear gingival erythema and necrotizing gingivitis. I'm mentioning this because I put them in the ENT category, not because they are ENT manifestations. Strictly speaking, they are the dental manifestations. But yes, if you see the oral cavity, if you see that you see a necrotizing gingivitis complaint coming in a child, and these are non-smokers. I mean, they are not adult patients. So in most of the times we have found that these are the patients. This is a very good and a very, what is known as a sort of a subtle presentation of the AIDS patient. Now, or, oral herpes simplex virus infection. This you can see here. This is a photograph of that. You can see punched out ulcerative vesicular lesions, very characteristic lesions, multiple lesions which you are seeing in the soft palates, and these lesions are, also they tend to recur. And here you can give oral acyclovir, again an antiviral drug, in the dose of 20 milligram per kg body weight for 5 times, and you give it for a duration of something like 10 to 14 days, and your patient, he responds to that very well. The other important thing which has come into existence, that is the oral human papilloma virus infection. Now, world over, not so much in India, by virtue of being in a tertiary care center, we have seen a few cases. But yes, if you see it outside, what we are seeing, that there is an increased incidence here. You can see this papillar lesions here, distinct papillar regions. They are quite different from the herpes simplex virus lesion. These are the papillar regions here, and these are usually seen in patients who are undergoing hard therapeutic regimen, number one. And of course, the adolescent sexual behavior. So be very careful when you see this. The AIDS patients who are having underlying HIV positive cases, if they get sexually active, they might present to you with this human papilloma virus infection. Now coming on to the neoplasms. Well, we all know the neoplasm. The commonest neoplasm to occur in an AIDS patient is a rare neoplasm, and that rare neoplasm is known as your so-called the Kaposi's sarcoma. It's the commonest oral malignancy in the HIV patients. They have a skin and a visceral involvement in 70% of cases. The hard palate is the commonest site. Now this diagram here is telling you about the hard palate lesions, red erythematous plaque-like lesions with some necrotic patches. See, and the best important thing about here is that the mucosa is very well maintained all over the lesion. That is something I want to highlight when you're seeing such patients. They are red, flat, asymptomatic and dark on symptoms. You have to do a biopsy. It's a very accessible site. You do a biopsy and you come to the conclusion that your patient is having Kaposi's carcinoma, and the treatment for these patients includes topical chemotherapy, but many a times we combine. In the oral cavity, we combine surgery with radiotherapy and chemotherapy. And I mean, of course, when you're talking about oropharyngeal manifestations, to keep in tune with the lecture, I said that you might find Kaposi sarcoma, but Kaposi sarcoma also has extraoral sites. That is something which all of us have to keep in mind. Now, the second very common type of the oropharyngeal manifestations is known as a non-Hodgkin's lymphoma. And if you see this lesion, and you compare this lesion from the what you saw previously, the Kaposi sarcoma, this too is a plaque-like lesion, this too is a enlarged lesion, but number one, it is not erythematous and it is having punched out ulcerative lesions. So there you are. So if you see a lesion in the oral cavity, a swelling in the oral cavity, and with punched out ulcerative regions, then of course you can be very sure that you are dealing with a non-Hodgkin's lymphoma. And this is very symptomatic also. It's not asymptomatic like a Kaposi sarcoma. It is it gives you intractable pain on chewing and swallowing. You have to do a biopsy. Well, a lot of research work has already been done in the management of the oropharyngeal manifestations, and what we do here, we use a CHOP regime, which is a standard regime, and we do a surgical debulking, and radiotherapy is also available for non-Hodgkin's lymphoma. The treatment protocol for a non-Hodgkin's lymphoma remains the same, which is there. We do not follow any special rules. I was talking to my medicine people. We do not follow any special rules regarding if you have a patient of HIV. But yes, the diagnosis is very important, and they tell me that treating this patient, they do tend to become resistant. They take a long time to heal up. So that is entirely a different subject which will we have to look into. Now coming on to some other rare lesions which you might see in an case of AIDS, the oropharyngeal manifestation. Now one of them is an oral hairy leukoplakia. So there it is. Now this oral hairy leukoplakia, it's a verrucous lesion which is seen on the lateral part of the tongue, and you can see this here is caused by an Epstein-Barr virus. You have to give trichloroacetic, glycolic acid, and podophyllum resin is the treatment of choice. Nowadays, if you have a patient of AIDS, we also give them a systemically acyclovir. The other very commonest condition is aphthous stomatitis. We all have at one time or the other experienced aphthous stomatitis. There is nothing new about it. The aphthous stomatitis, it has of three types. One is a single ulcerative lesion. It may be, multiple lesions in the oral cavity. And lastly, you have a third viral form of it, which is known as herpetiform lesion. And that is also seen very commonly in AIDS. You have these lesions. They usually, in a normal person, they come and go by themselves, but in AIDS, they have a long protracted course. They are there for a very long period of time, and the treatment protocol remains the same. You have to give your patients a large doses of antioxidant drugs along with the B complex and of course steroids, and in some rare cases you might have to give these patients immunomodulators. But as I told you, in AIDS, aphthous ulcers are not so commonly seen, and that is why I have put them in the last slide. What you will see more common is a candidial thrush. You see the human herpes simplex virus disease, the vesicular punched out lesions. You also see more commonly nowadays, the Western literature tells us, although we're not seeing them much in India, is a papillary lesion. And these of course are a few other rare lesions that we see here in the oral cavity, which are regarded as the rare ENT manifestations of the AIDS. Now coming on to the neck manifestations. Now neck manifestations, are generally regarded as very benign, but although they are the second most commonest AIDS manifestation in children, and you see lymphadenopathy, two or more sites are involved. If they are involved for a duration of more than 3 months, so then you have it. So you have it in tuberculosis, you have them in lymphoma, you have them in Kaposi sarcoma. So all these type of lymphadenopathies you can encounter here. The message is, if you're having a multiple lymph node involvement, not responding to your regular treatment for a time duration of more than 3 months, then you probably suspect that these are the ENT manifestations. And similarly for the salivary glands, the commonest salivary gland to be involved is a parotid gland, and a very classical bilateral parotid swelling is seen, which is so commonly seen in AIDS. In fact, if you see my own personal clinical experience is that if you see a case of bilateral parotid swelling, you must suspect that the patient is, generally having what is known as an AIDS manifestation. Now, from here onwards, we will switch off to the third commonest manifestation of ENT in patients of AIDS. Now, these are the otitis externa. Now, this is the infection of the external ear. It's a part of seborrheic dermatitis, and of course, you have to give these drugs like zinc pyridine, selenium sulfide, and ketoconazole. Now, this is seen, but this is a very mild sort of infection. Most of the otologists, if this is the only presentation for an AIDS patient, they are most likely to miss it. Now, what is more important is the secretory otitis media. Now, the accumulation of sterile fluid in the middle ear, and that is known, and it leads on to deafness. Now, in the patient of AIDS, these cases are more predisposed because they are more predisposed to repeated bouts of acute otitis media, number one. And number two, they are most likely, they are most likely to be seen in cases of adenoid hypertrophy. So you have these two conditions which are more prevalent in these patients, in AIDS patient, and therefore as a secondary to that you might have secretory otitis media. Now the diagnostic investigation for this is the impedance. Okay, so that is important, like for anything, and like we treat a case of secretory otitis media, we give them antibiotics for a duration of 4 weeks, and if there is a failure of this treatment, these patients they switch over to grommet insertion. What I want to emphasize here is that there is no differentiation in the treatment protocol, but yes, there is a lot of problems. If you have a patient of AIDS, they generally do not respond to antibiotics, and the two predisposing factors which I told you, like the adenoid hypertrophy and repeated bouts of acute suppurative otitis media and AIDS, they are the hypertrophy of the tonsils and the repeated bouts of acute suppurative otitis media, they predispose your patient to secretory otitis media. Now the other is of course infection. So you have infections, you have acute otitis media, you have a chronic otitis media. Acute otitis media is pain and discharge for a duration of less than 3 weeks. A chronic otitis media is the one which lasts for more than 12 weeks. And there is no differentiation in the microorganisms. They are caused by Pseudomonas and Staph aureus, as we see in the general population, and they can lead to atticoantral and tubulotympanic type of disease. But what is more important is the rare infections. Now tuberculosis has had a resurgence in general in all patients of HIV, and ear infections are not exception to the rule. So whenever you see a case of multiple perforation, or you see a grayish sort of a chicken sort of a granulations coming up, and let me tell you one thing, that the incidence of granulation surprisingly in a patient of AIDS, I was reading, is very, very low. So you have this, all of a sudden you will have your patient presenting to you with facial nerve palsy. So these are the cases, which you have to consider to be, involvement in what is known as your tuberculosis of the ear. And sometimes what we see is we see the oral polyps in the ear. Now once you see these oral polyps, they have been associated with some very rare infections like the Pneumocystis jirovecii. Now this is an infection which is usually associated with pneumonia, but whenever in a case of an AIDS patient, if you have a polyp, an oral polyp, so that most of the time this sort of a rare infection we have seen in them. The treatment is of course the tympanoplasty with mastoid exploration. So when you have a case of chronic otitis media, these patients have protracted discharge coming out, they might have polyps, and it's very difficult to get hold of control of the discharge, and according to the ethics of the treatment, they require mastoid exploration, and we in our institution have done mastoid exploration for AIDS patient, and we have found a very extensive disease, mostly a cholesteatoma disease. The granulations are very, very less. Then another infection which we don't see too much these days is the autosyphilis. And if you see an autosyphilis or a TB or a syphilis in a normal patient, in a child who's having chronic suppurative otitis media, then of course you tend to think that yes, probably your patient might be harboring HIV positiveness in himself. So that is one clear message I want to give. Now coming on to the nasal manifestations now. Now when we talk here about the nasal manifestation, the commonest infection is of course the rhinosinusitis. And what do we have here in rhinosinusitis? We have a protracted nasal discharge and blockade for more than 12 weeks. We have repeated and recurrent bouts, and the commonest organism to be associated with this rhinosinusitis is streptococcus pneumoniae and H. influenza. But before I go ahead, there are two things I want to highlight. Now, number one, that they have repeated and recurrent bouts, as we will see subsequently in the lecture as well, that they tend to have a very protracted course of sinusitis. Sinusitis not getting resolved for maybe 4 or 5 weeks, and thereafter you might have this what is known as they have a strong allergic component as well, IgE. So treating this patient becomes a very headache for you. Chronic rhinosinusitis in AIDS patient, we encounter a lot of difficulties, and in a city like Delhi where pollution levels are very high, that also adds to a very strong contributory factor. In fact, we do miss out on most of the cases, and later on we come to know that these were the patient of AIDS, and we presume that this basically due to pollution that they were having protracted sinusitis. So the message is that if you have protracted sinusitis which is lasting for a longer duration of time and occurring very frequently, like 4 or 5 episodes in a year, right after treatment again the patient comes to you with chronic rhinosinusitis, again he comes to you with sinusitis. So these are the patients which you have to very carefully monitor. Now, the treatment for them is, of course, is a general treatment protocol that we are following, antibiotics for 6 to 8 weeks. This, of course, is followed by steroids. A word of caution here about the steroids which you're going to prescribe to your patients. There is a risk of development of Cushing syndrome with the use of intranasal steroids in patients on ritonavir containing antiretroviral regimen. So that is a work of caution, that if your patient is having an antiretroviral drug, he might develop Cushing syndrome. The failure of the treatment leads to FES. We do FES in AIDS patient. According to the WHO guidelines, these patients cannot be refused surgical treatment. Whether it is in the ear, you have to do a mastoid surgery, or whether you have to do a FES. You have to be very careful, and just we as doctors have to take a lot of precaution. You have specific gowns and all, but what the message is very clear, that if your patient is having polyps in the nose, because there is an allergic component, you have to treat them, and these are one of a few important manifestation of the AIDS in children. Fungal sinusitis. Now, fungal sinusitis is very dreadful. AIDS is a very strong predisposing factor. We have a lot of cases of allergic fungal rhinosinusitis reporting to us, and almost Candida, Aspergillus, mucormycosis, all are involved. Mucormycosis is very much fatal. This leads to bony destruction of the nasal bones, the palate, and the skull base. They have to do the treatment is with lysosomal amphotericin B, and lastly you have to do a surgical debridement. So that is very important. The last point written down here, as you can see, is fatal. So nasal fungal sinusitis in an AIDS patient can be very fatal. Now, it is a general protocol of management in our institution that whenever we have a fungal case, we screen them for AIDS, and we also screen them for that is for diabetes mellitus, these two conditions. And believe me, many a times we do detect them. In fact, all our surgical patients, whether they are undergoing chronic rhinosinusitis for chronic suppurative otitis media, also nowadays we have started screening them for AIDS. Although I cannot tell you the exact incidence, I don't have the data at my tips right now, but yes, over a period of time we have found that we do detect 1 or 2 cases who are of AIDS in a year. In a year we do get 1 or 2 cases who are undergoing surgical treatment, that he is a case of chronic suppurative otitis media and he is HIV positive. And similarly, same holds true for fungal sinusitis also. We get in our country a lot of allergic fungal rhinosinusitis, and here also our incidence of new cases is about 1 to 2 per year. And that's why I'm emphasizing that these two, I mean a discharging ear and a rhinosinusitis, it might be fungal, and a fungal ball may be there. So these are very important ENT manifestations of HIV. Neoplasm, well, adenoid hypertrophy, I could have kept it separately, but then it's a nasopharyngeal lymphoid mass. I told you when we were discussing secretory otitis media that most of our patients, they do have adenoid hypertrophy, and then of course lymphoma and Kaposi sarcoma. When I was discussing oral cavity lesions, I told you that these are very common sorts of malignancy which are seen in patients of HIV. And so similarly here also in lymphoma and Kaposi sarcoma you see. And one last thing, epistaxis. Now this is of course attributed to idiopathic thrombocytopenia seen in cases of HIV patients. So even if a mild symptom, like basically in the nose you have two symptoms. One is sinusitis and other is epistaxis, which immediately alarms you. Nasal blockade, luckily for us, is not a very important sign for AIDS. So whenever you have epistaxis in a child, you must see that whether he or she is not having an idiopathic thrombocytopenia, which in reality, might be underlying an HIV case. So that is the message, although you see it rarely. Okay, now what are the other rare manifestations that you can have? We talked here about the oral lesions, we talked here about the ear lesions, we just talked here about the neck lesions, we talked here about the nasal lesions as I classified them, and I told you which is the most common one. But there can be some other abnormalities that we have encountered and which are also clearly mentioned in the literature. And when you start suspecting that yes, your patient is the one of HIV positive case. Now these are of course infections and tumor in the tonsil. Unilateral enlargement of the tonsil, should alarm you. And if you send them for after doing a tonsillectomy, you send these patients for histopath examination, and we have got cases, one odd case I remember, which was diagnosed as HIV positive, or we came to know about that while pre-screening to surgery, but and of course it came out to be lymphoma thereafter. So that is one case I'm sharing with you, but it's very well mentioned in the literature. You in the larynx, you can have candidiasis, you can have Kaposi sarcoma. Candidiasis, of course, in an extension of oral thrush. Kaposi sarcoma, we know vocal cord edema. This is there. You call it Rinke's edema. You have a bilateral vocal cord edema in children, a change of voice. That is the only indication. That is the only clinical symptom which your patient is coming. And to examine these patients in the OPD becomes a problem. You have to do a fibro optic laryngoscopy in them. And once you do a fibro optic laryngoscopy, only then you come to know that yes, your patients are having a vocal cord edema. And lastly, you have your recurrent laryngeal nerve palsy, and that of course, because of AIDS, you have opportunistic. It's basically nowadays being attributed to viral etiology if it is a unilateral one. I have not seen a bilateral vocal cord palsy being caused by in a patient of AIDS as per se. Yeah, of course, it's followed by some rare tumor or something like that. But yes, we do have cases of unilateral vocal cord palsy. Lastly, sometimes we do have Sjogren-like syndrome coming up in children with ENT manifestations. If you have a Sjogren syndrome, of course, we don't see the Sjogren syndrome much. If it involves the submandibular gland, rarely it comes to us. It's the medicine people, the pediatric people who really diagnose it first. The other important thing to remember here is the esophageal candidiasis. Now, this is a very dreadful thing, you have an oral thrush, I told you, which is the commonest manifestation of AIDS. And once it starts spreading, if you're not able to manage it, then you realize that, it starts going to the larynx and then it starts reaching to the esophagus. And the clinical features are very clear, refusal to feeds, drooling, or dinophagia and dysphagia. The child becomes listless and restless. It's a very pathetic sight, and for that, you have to give them IV antifungal drugs, fluconazole, and you have to give them for a long time, something like 21 days. And let me tell you one thing, that the prognosis is not very good, because you can't repeatedly do an endoscopy to see whether the lesions are resolved or not. So it really becomes a problem here. Lastly, a ranula. Now, the recent review of literature, very surprisingly, has told us that even a case of ranula can be an indication of HIV. It was not there previously. Now, what happens that in a patient of HIV, we have lymphoid hyperplasia. And once the lymphoid hyperplasia occurs in the floor of the mouth, it blocks the duct of these small glands there. And as a result of that, you have a retention cyst, and that retention cyst is known as ranula. So once you're removing ranula, now there is a lot of literature coming on this, that ranula in children, which we generally used to think that it is a congenital ranula, it might be underlying disease of HIV. So that is another very rare manifestation that I have just mentioned it here. That is, we have not seen any case till date. So what is the magnitude of problem? I told you that, oral candidiasis. Now this is very important. Oral candidiasis is present in about almost 80% of the cases. So that's the very commonest lesion we have. This of course is followed by your cervical lymphadenopathy. See, 70% of them are going to bear. Now this is a data which I am quoting from this infectious disease report 212. I mean, we have not tabulated our own data, but this data is there. And then of course you have the other important cause is otitis media, and that is the ear infections. So that is very important. And then subsequently you have the other conditions coming in. And that is why at the outset I told you that the commonest is the oral lesion. At the second number we have the neck lesions, and then finally you have the ear problems. And this is roughly their data. As you can see, periodontal and gingival disease is just about 20%. Herpes simplex virus varies from 1 to 24. Oral hairy leukoplakia is seen in 2 cases, and so on and so forth. So just to tell you that we have a magnitude of problem and how they are, that I cleared right at the outset of the lecture. Now, what is the clinical diagnosis? I told you there are certain predisposing factors, but yes, apart from those predisposing factors, there are some clinically important diagnostic indicators when you can suspect that yes, your patient is having HIV, and this of course should be known to all ENT doctors. Now, one is of course the need for 4 antibiotic courses in a year, number 1. Number 2, occurrence of 4 or more than 4 new infections in the year, and of course thirdly the development of pneumonia twice a year, and lastly the occurrence of bacterial sinusitis 3 times a year. So there you are, these are a few predisposing factors. Then of course the use of preventive antibiotics, and lastly you have an unusual bacterial infection by rare pathogen. Now this of course has a geographical bias. In India, as I told you, Pneumocystis girovecii is the one. So if you're able to diagnose these things, antibiotics frequent use, or you have to put your patient on preventive antibiotics, or the repeated bouts of rare infections and all. So these are the ones where you clinically start suspecting that yes, your patient is the one who might be harboring what is known as a HIV positive. He might be HIV positive. So then, to conclude the summary here, now the first important thing, the take back message is that ENT manifestations are prevalent in 80% of our pediatric population, number 1. Now it is intrinsic part of diagnosis but not a surrogate for HIV testing. Okay, so however good clinician you are, I mean, you've got to back it up with your good HIV testing. And the important manifestations in order of prevalence, the first is the oral manifestation. You have to look for oral candidiasis, the herpes simplex, and the human papilloma virus diseases, papillomatus, and the vesicular punched out ulcer appearances. Then of course you have at the second level, you have the neck manifestations. You can have the lymph nodes and the parotid swelling. And this of course you have the chronic otitis media. So that is very, very important. Chronic otitis media, discharging ear, the disease is very much prevalent in India. We take it very casually as such. I mean, less to say that we diagnose AIDS on that. We're not even bothered about treating chronic suppurative otitis media. You'll be surprised to know that in the pediatric population, its prevalence is 4.79%, and anything above 4% is a health problem, but we are not bothered about it. So these are the patients who might present to you with what is known as, they might be having underlying HIV, and or they may be having overt AIDS infection. Nasal manifestations, of course, sinusitis, that is another very important cause. And then you can talk here about the management. You have the multidisciplinary approach is required. We can only treat the symptom. As ENT, manifestation is a symptom. You give your patient symptomatic relief. The underlying treatment has to be taken up by an oncologist, immunologist, and a pediatrician. A pediatrician is a very important part who takes care of the holistic view of the AIDS disease. Since this AIDS hits the immunology very badly, so nowadays even immunologist is a part of the team. And lastly, oncologist. Why? Because you are having Kaposi sarcoma and you are having lymphomas. The AIDS, they might or might not benefit from the traditional treatment which is mentioned in the literature, although there have been no change in the guidelines, but yes, these people have to be involved in the treatment protocol. So what is the take home message? So Act Against AIDS is a proactive multidisciplinary approach. Well, I don't know, doctors, health personnels, government and people, everyone has to be involved at all the levels here when we are talking here about the AIDS. Doctors, of course, the health personnel. Unfortunately, in India, it is the health personnel who are interacting with the patient first. The government has to go on a massive education drive. Apart from giving funds for the treatment of AIDS, that of course is a part of them. Training the health personnel, no doubt, but above that, there has to be a reach to the people. And last but not the least, people themselves have to be receptive for it. Now, they are the end users, and that is only possible if we repeatedly spread the message. If we are not spreading the message, then probably our patients would never come to know that what are the ENT manifestations of the AIDS in their patient. And again, I'll repeat that 80% of the patients I just told you of HIV, they have a common ENT manifestation. They might be diagnosed by an ENT manifestation, so we cannot forget that very important thing, and you must keep it at the back of your mind. So then, thank you so much for giving me such a patient hearing. Doctors prescribe medicine of which they know little, to cure diseases of which they know less. That is true for ENT surgeons. We ourselves are blind, mind sees what eye sees what mind knows, and that is it. We ourselves don't know when we see a patient that whether he is a case of HIV, and we start just treating the patient like that. The condition deteriorates, and only then we realize that, oh my God, he is a case of AIDS. So, with these words, I conclude my lecture. Thank you once again. Good afternoon. Questions, Lenny? Okay, if there are any questions regarding this lecture, they are most welcome. We'll answer them to the best of our academic and clinical knowledge. There are some questions. Okay.